Good afternoon, everyone. I am Garrett Schmidt, the managing editor for ACOExhibitHall.com, and I would like to welcome you to today's webinar, Transitioning into a Successful Risk-Based ACO. Today's webinar is part 2 of a 2-part series and is entitled How to Prepare for Risk. In part 1, we discussed the importance of moving to a risk-based model and methods for financially protecting your ACO in the process. If you would like to hear the recording, it is actually available at ACOExhibitHall.com in the library at the Risk Strategies booth, which is also where today's presentation will be available as well. Today's presentation will be a continuation of that discussion and will better prepare you for the transition to downside risk. All attendees, including yourselves, have joined the webinar today in listen-only mode, and you will each have the opportunity to send questions during the presentation using the little question mark icon at the top center of your screen. And we'll be able to answer as many of those as possible in the QA session at the end of the presentation. These questions are also being recorded and will be part of that recording. And even if we were unable to answer your questions during the allotted time today, we will follow up and answer them via email after the webinar. As with part 1, again, this is being recorded and will be available for your review at the website afterwards. In today's webinar, our presenters will be Chuck Newton, who is the Senior Vice President for Risk Strategies, Andrew Webster, who is the ACO Actuary for Validate Health, and John Schmidt, who is the Managing Director for Reliance Consulting Group. Welcome, guys. I would now like to hand it over to John, who will begin our presentation with an overview of the agenda for today. Welcome, John.
Thank you, Garrett. Good afternoon, everyone. Garrett, I cannot advance these slides, so I may need you to do that. While we're getting squared away, I'll say in part 1, we covered why the transition was necessary to risk, and that was largely determined by and supported by CMS data that was recently released and reported in the Accountable Care News. And then we talked a little bit about how some risk protection tools can help moderate that, moderate that risk. This part, in part 2, we're talking about a deeper dive as far as how to transition into risk. And so as a result of that, let's take a look at the agenda for today. So I'm going to be covering the first 3 bullets here, the standoff between ACOs and CMS that you've probably been reading about. We'll talk a little bit about those implications. We'll talk about the 10 reasons ACOs can fail, and then we'll talk about I'll talk about ACO risk management and the 5 operational steps that need to be taken for an ACO in order to get ready to transition to risk. Then Andrew's going to pick up at that point, talk about key actuarial considerations, and then Chuck will come in after Andrew to talk about risk protection tools and examples, and then we'll finish up with the discussion questions and answers. So that's how we'll proceed here, and then we'll close on out. So again, I can't advance the slides there, so I'll need somebody to do that. Let's go back. Okay. Okay. Let's go with this one. So we're going to kick off. We're talking about the fact that the National Association of ACOs surveyed their membership, and they found out that 82 of the ACOs that were started in 2012, 2013, those are the ones that are coming up on risk, and 71% said they are likely to leave the MSSP program if they're forced to take on more risk. That created next slide, that created a problem as far as CMS was concerned. And so Joseph Grogan, who's the Associate Director of Health Programs at the Whitehouse Office of OMB, Office of Management and Budget, he reported that there are a lot of broken promises and failed estimates in the Affordable Care Act, The hope and promise of this complicated value design is one of them. He's talking about, in that first paragraph, accountable care organizations and the fact that they have been unable, the majority of them, to save Medicare money. We talked again a lot about that in part one. It goes on in that third paragraph, say policy changes are therefore coming to the MSSP program, and they've been posted on the OMB website. And the rule that's been posted is intended to facilitate ACO's transition to downside risk. Now, before we go to the next slide, I want to mention that there has been a response to this standoff. And insurers, for example, are now spending billions to acquire provider practices. Some of that's reported in Modern Healthcare in the June 4th issue recently. And it gives reports about how many providers and what type of providers are being acquired, and again, for an expenditure of billions of dollars on the part of insurers to do that. Simultaneously, hospitals and health systems are acquiring provider practices at rapid speed. Reported that 5,000 independent practices were acquired by hospitals in fiscal year 2016. In 1 year, 5,000 practices acquired. Modern Healthcare refers to the whole situation as kind of an arms race between insurers and health systems. This webinar really proposes a different option. We're proposing that it's possible to help independent physicians and hospitals as providers. It's possible to help them learn how to manage risk in an ACO structure. So that's what we're going to proceed with now. So next slide. So why ACOs might leave? Okay, so this was reported also by NACOs, the National Association of ACOs. And in their survey of asking why MSSPs would leave the program and what their objections to risk were, 40% of them said, you know, the amount of risk is just too great. It's too intimidating. Chuck's going to discuss in a little bit later into the presentation about how that risk can be moderated. 40% of them said that they're concerned about unpredictable changes in CMS rules. And, of course, nobody controls CMS on the provider side, so that's possible. Andrew's going to talk about some implications about how to moderate and ameliorate the unpredictable changes. They're not as unpredictable as they may seem. 40% talked about the desire for more reliable financial projections. Andrew's also going to talk about that. And then 36% said they have concerns about their past performance. We've worked with a number of ACOs around the country, and I would tell you that, as we mentioned in part one, the past performance of MSSPs, track ones, for example, whether they've been successful or not successful in earning shared savings, is not a good predictor of whether they'll be successful in bearing risk or not. There's a lot of factors that come into play that you're probably aware of, but things like benchmarks in different geographic areas, some are low, some are high. Some market areas it's easier to achieve savings than others. So some of the programs that got started, some of the MSSP programs that got started, are much more in a better position actually now after gaining some experience, learning how to manage risk better, to achieve better performance under these upcoming risk models. Okay, let's go to the next slide. This is kind of the what, if you will, of the problem. We talked about why in part one of the webinar. This is kind of the what is the problem here. So there was a survey of ACO experts reported in last month's Becker's Hospital Review, and it gave these top 10 reasons of why ACOs fail. And so any given ACO can fail because of these 10 reasons. In the interest of time, I'm going to buzz through these real quickly, and I'm just going to say from 1 to 10. The ACO is 1, not big enough. 2, the staff isn't trained enough. 3, they're not in an accountable culture yet. 4, they're not integrated with other healthcare providers. 5, they're not coding correctly. 6, they're not managing patients effectively yet. 7, they're not staffed with population health management staff appropriately. 8, they're not given the data that they need. 9, the physicians are not engaged or on board, and 10, they're not correctly reporting in their quality measures and tracking that enough. So that's a lot to swallow, right? So ACOs need a lot of help. The good news is that help is available. It's available from multiple sources. And so the intent of this webinar is to give a good first step to help to show that, yes, there is help available and ACOs can rise to the challenge of taking on downside risk. So let's go to the next slide. So the next slide talks about 5 essential steps of ACO risk management. I'm going to go through and give you an example of each one of these steps. But for this purpose, let's just say that risk identification, it begins with identifying loss, exposures, and limits. You're going to understand a little bit more about that in the example we're going to give with respect to looking at downside risk models in a minute. Then step 2 is risk avoidance, and this has been a big issue. So physician members of ACOs have had a tendency, as we all know, Dad, to be risk adverse. There are ways to move the physicians in a more comfortable way to get ready to take on risk. I'll give an example of how to do that in a minute. Risk prevention. Here's the point that gets into the weeds a little bit more, and that's to develop action plans that will actually reduce the likelihood of losses. I'm going to give you a pretty detailed one example in a few minutes, but there's a need to really do quite a bit of effort in the action plan side. For risk reduction, that's assessing the risk readiness and what is needed to be developed. We're going to share with you a risk assessment tool in the next few slides and let you take a look at how that could be kicked off. And then finally, risk transfer, and that means acquiring reinsurance and the protection from captives, and Andrew and Chuck are going to talk more about that. So let me go to a couple of examples with the next slide. Step 1 is let's talk about moderating ACO loss exposures and limits. So what happens here is we've taken each track 1, 1+, 2, 3, and next gen, and we've said, okay, let's take a look at the next 2 columns, which really deal with loss and loss limits, and then the last 2 columns, which really deal with gain, shared savings gains, and gain limits. So we all know that in track 1, the shared loss rate, you don't know loss exposure, so that's not applicable. The shared savings rate is 50%, and the performance payment limit, which is the cap on total shared savings in any one year, is 10%. So some might wonder, why do you cap it? You cap it because the intent is not to incent more than what is reasonable as far as incenting shared savings. So we want to be able to do a realistic projection of that, and that's why the cap is on there. Talk a little bit about track 1+. So you can see that the shared loss rate under track 1+ is 30% of the total cost benchmark. And the loss sharing limit is the lesser of either 4% of that benchmark, the lesser of, or 8% of the revenue of the ACO. So the shared savings rate, again, no change there at 50%, and no change in the performance payment limit at 10%. Track 2 and track 3, you can see are pretty self-explanatory. It goes 40%, 60%. Loss shaving limits are between 5 and 15% depending on the model. And the savings rate increases because the risk is increasing up to 60%, up to 75%. And the performance payment limit at 15 to 20%. Next gen is a little different. Now we're talking about the potential of full capitation, even under 100% of risk. And in that model, there's a symmetry between the loss shared rate and the shared savings rate, 80, 100% with the shared savings. Over in column 4, 80 and 100% of the shared loss rate. Same holds true at the loss limiting and the performance payment unit at 5 to 15%, symmetric with the loss and the gain side at 5 to 15%. So we're going to talk a little bit more about that. Chuck will provide an example later of a track 1+ risk model, and we'll model that on out for you. Let's go to the next slide. So we talked earlier when I talked about step 2, physician member culture change. This is something that we found in working in different ACOs and in different states is a very significant problem. How do you affect physician engagement? Well, we start out with looking at a bell curve that I think exists in any ACO. The distribution of it might be different, certainly would be in any ACO. But the key here is how do you affect physician influence into the physician culture? One way is to find those champions that are in support of getting into an effective, successful risk management ACO and letting them have a role to play in the governance, the board of directors, helping them get into positions in the medical committees, because physicians listen to physicians, right? And it's important to have a representation of the physicians who are champions of moving forward with the ACO and risk readiness to be included in the medical committees. Chief medical officers, regional medical directors, department chairs, et cetera, are important to play a role for them there. Operational meetings and conference calls, very important that they participate in those and give their feedback. I've had the opportunity to listen to a number of those, and it's been really impressive with what I've heard some of the physicians be able to share, and to see in some of the commercial payers make corrections as a result. Commitment, culture change just means getting them ready for risk readiness, and incentive compensation, letting physicians have input into that process as well. If you look at the bell curve, you're going to start out with some champions. Those are strong advocates, of course, between risk readiness. They're going to influence those who are kind of early adopters or willing to move in that direction if they know more. When those early adopters come on board, they influence what we would call the early majority. Those are the positive physicians, but just aren't ready to move in mass yet, but they will be when they learn more, become influenced more by the physicians that have become the champions and have moved over in the positive state. And then those early majority are the ones that the late majority, the ones who kind of negatively predisposed to this, they're influenced by the early majority ones because they'll look at that and say, if he or she are doing that, then they're a lot like me and they think like me, so I may go that route. The detractors are going to be those who don't want to be involved in the risk program. There are ways to talk about doing that. Andrew's going to talk a little bit about that in a few minutes, but it may come down to the fact that they just don't have a role to play in the ACO. Okay, let's go to the next slide. Step 3, I talked about an example action plan to prevent the likelihood of losses. This is deep stuff. These action plans can take pages and pages to develop if you're really going to do an effective job of minimizing losses by taking specific actions. This is just one. This is one example called a centralized transfer center. And the centralized transfer of patients within a ACO's hospital system is what this concept is. I won't go through everything, but it just says basically the centralized patient transfer center has a one-call process where hospitalists provide predetermined criteria. So if somebody's going to be transferred, centralized patient, one call comes in, there's criteria to be looked at, patient can be moved and transferred as a result of that. One of the outcomes of this is that it will replace bed day capacity. In other words, it will improve bed day capacity. Hospitals will tell you that the most financially beneficial day for them is when patients are first admitted and are generating charges. They don't do well financially if patients aren't transferred out when they need to be transferred out, and that's consistent with good care as well. Preliminary financial impact, $5.6 million. This is just an estimate specific to this example. Population. Here we're talking about a regional opportunity of maybe 1,000 transfers a year. This is an ACO with a regional market. In other words, multiple hospitals in different regions, maybe different counties that are contiguous in the ACO service area. Key elements mean that these are the elements that have to be in place in order for this particular loss-saving initiative, centralized transfer, to be effective. One regional number, predefined criteria established by hospital and specialists, coordinate transportation, or whatever that means in that service area, make it offered, available to all the regional hospitals, will require some marketing effort, and all regional transfers and that are managed through this centralized system. Well, you're going to run into some barriers trying to do this, right? So as you develop your action plans, you're going to take a look at what are these barriers, what are these potential problems we're going to have. Well, in this one example of a centralized transfer center could be the inability to secure a hospital specialist agreement on what the acceptance policy should be. Could be objections by some of the hospitals. Could be have to get a right or no second chances with hospitals. Well, that's unrealistic expectation. You've got to kind of sort through all that out. Unwillingness of regional hospitals to use the ACO center. They have existing relationships. So you get the idea. There's potential problems that have to be worked out as these action plans are developed. Let's go to the next one. Next slide. Okay. Step 4, I talked about risk reduction by readiness assessment. Well, in this model, what we have done is we've developed with the input from actuaries, reinsurers, underwriters, and risk management consultants, we put together a risk readiness assessment tool. In this tool, there are 8 criteria, the 8 criteria you see here displayed. Under each of those 8 criteria, there's about a half a dozen bullets that address the readiness of the ACO. I'm going to give you one example of that in the next slide and let you know at this point, we're glad to send you the complete assessment tool upon request. It was just too big and too wordy to address in a slide presentation like this. Let's go to the next slide. Here's one example of a risk readiness that would appear on the readiness assessment tool. This one has to do with financial risk management. You see that in the gray area. The risk readiness assessment tool takes these different criteria and it says, okay, is development required? Do you have some capabilities in this area? Is it already in place and functioning? So in that case, we found it was helpful for each key organizational unit, like the governance, the chief medical or clinical operations, care coordinators, et cetera, in ACO, to ask them as separate units to give their input in terms of the readiness with respect to these criteria. Some may say, I have no idea. That's fine. But we're looking for, is there a consensus or is there a misunderstanding of the readiness with respect to the individual criteria we're looking at? In this case, for example, we're looking at medical service expense management capabilities. Do we have that capability? Is it evident? We worked with one ACO in New York, and we found by working and focusing and developing medical expense management tools and capabilities and analytic reports, we were able to reduce the medical loss ratio from 89% to 82% in 18 months. That was an impressive financial gain. Another criteria would be the process to assess financial risk. Andrew's going to talk about that later, so I'm not going to go into much of that at this point. Cost accounting capabilities, are they in place across the episodes? Because if they're not, you won't be able to do an effective job of developing bundles in bundle payment systems. Provider health plan partnerships, we all know that there's been a history of low trust between payers and providers because of the fee-for-service history where there's been win-lose kind of negotiations. But it's important in developing financial risk management readiness to understand that there is a collaboration available with respect to payers in working together for provider health plan partnerships to say, how can we deal with each of these areas, including how can we work together to achieve mutual financial goals. Okay, those are the 4 steps. I'm going to hand it off to Andrew at this point and let him go into the top factors determining ACO. Andrew.
Thank you, John. These are the 5 top considerations that I've seen ACOs make when they're deciding whether to move down to downside risk and which risk track they should choose. And really what we refer to here is the risk appetite. And so these are 5 rules of thumb. The first one, ACOs receive a wealth of data for assigned beneficiaries, and that historical data can be adjusted to each of these future downside track rules, and it can be used to estimate how well the ACO would perform under each track. So the more the ACO has a handle on their data and have worked with the data, the more likely they're able to comfortably and confidently really take downside risk. The second one is if the ACO does not have hospital participants, so it's physician only, then the Track 1 Plus track really offers the lowest downside risk option while still qualifying for the 5% MACRA AAPM bonus. So that's something to definitely look at if it's a physician-only ACO. And John already showed some of the loss limits and other contract provisions in each of the tracks. And although the physician-only ACO has less downside risk exposure through that 8% of revenue maximum loss limit, they do actually still partake in a 50% sharing rate. So it's really a good way for the physician-only ACOs to dip their toes into downside risk, and was designed for that purpose. If the ACO is planning on making participant list additions or any other structural changes, M&A, all types of things that hospital systems or physician groups are going through, if they're looking to make those changes for the performance year, the upcoming performance year, that might be an indication that the ACO is a little bit more risk adverse. So it's an important consideration as to how much that historical data is going to be changing, and how much of a handle the ACO can get on the 2019 performance. Fourthly, the prospective versus retrospective attribution is a major consideration when selecting the right track and how much risk the ACO wants to take. Prospective attribution is advantageous for providing a timely patient list, and this allows the ACO to have the most time to manage and identify patients that should be care managed. However, a retrospective assignment track really has the most accuracy and alignment with the performance year. So in practice, what we've seen is upwards of a 30% churn or difference between these two populations. And that adds a lot of variability and really makes the ACO more risk adverse. So, the more that the ACO has managed attribution and thought through the different attribution models and even modeled it using past data, it's really a key for confidently taking more downside risk. And finally, the MSSP ACOs in their second, third year agreement period or later, as of 2017. So all ACOs as of 2019 that have been in for 2 agreement periods will now have a regional component to their benchmark. And this regional component is based on the beneficiary county, not the provider county. So that's one thing to keep in mind. And ACOs with a high regional benchmark may be able to seek more risk in a higher downside risk track to fully capture what we term arbitrage, where there's a certain regionally higher benchmark versus the historical benchmark that the ACO has. Now, these are the first 4 things that an ACO should do prior to entering a downside risk track, and this gives the ACO the best shot at earning shared savings, avoiding losses, right out of the gate. So definitely analyze the impact of regional benchmarking on your ACO. If there are counties where the ACO has regional arbitrage opportunities, then focus on those counties first. One of the things that I hope comes across in this is that you don't have to take downside risk immediately on everyone. So when we're prioritizing who to take downside risk on and which part of your ACO can take downside risk, the parts of the ACO that serve beneficiary counties that have regional arbitrage opportunities should be focused on first. Secondly, look at the variation among your physician participants. And John had shown a bell curve in terms of the readiness level of the physician participants, but even analyze from a cost perspective which physicians are contributing the most or least to the savings, and transition the physicians with the track record of success to downside risk first because they're ready for it. And then you can learn with them and definitely reassess the compensation strategy for those physicians and, offer a higher potential for reward. And in some cases, you can even offer a withhold, and that gives the ACO potential to hedge their downside risk exposure. And that's really if the physician culture is amiable to that, which is always a challenge, but withholds are a great way to hedge downside risk if the physicians have the appetite. So finally, use historical data to estimate downside risk exposure under each track. Use your data to model the prospective, retrospective assignment, and really how that fits in with your organization and your care management initiatives. And also, when you've chosen a track, make sure to model the best contract provision, the financially optimal contract provisions, such as the minimum loss rate, minimum savings rate. The ACO actually does have some flexibility in choosing those parameters for a downside risk track. So that's something new versus track one. The ACO's pretty much forced into a assigned beneficiary threshold for the MSR, the minimum savings rate. And then one thing that's overlooked by ACOs when ACOs are focusing on cost management is to really make sure that the benchmark is managed. And you do this by appropriately capturing risk scores. And this gives an accurate view, both in the regional and the historical benchmarking methodology. It gives an accurate view of the population risk and really the risk-adjusted cost target for your ACO. So a little bit more on the regional arbitrage. This chart shows significant regional variation for one of the ACOs we work with in Illinois, and this ACO had 13% variation. If you look in that per capita expenditures, it's a 13% variation among the counties in Illinois in which they have been beneficiaries. And then if you look on a risk-adjusted basis, there's 8% variation. And it's important when talking about regional benchmarking to think on a risk-adjusted basis, where it's that first one, Cook County, you see is a high per capita expenditure of $10,300. But then when you divide by the risk score, you actually see something we call efficiency, which is $10,000 per beneficiary per year. And that's for a risk score of 1. So really focus on the efficiency, and it's what the shared savings formula uses as well. So that's important. Here, the risk-adjusted cost showed that it's best for the ACO to focus on DuPage and Kendall counties, and you see that's a 10,200 and 10,400 benchmark, and so that gives a lot of leeway for the ACO when they're considering which provider participants to move in first. Those with beneficiaries in those counties gives a lot of budget for the ACO to work with. And note that by ACOs focusing on the counties that are the least efficient on a risk-adjusted basis, those with the highest risk-adjusted costs, the ACOs are really helping the mission of the MSSP program by prioritizing the costliest counties. And this arbitrage helps to fund a lot of the care improvements that an ACO makes, and eventually will disappear over time as more ACOs concentrate in that county. But it's really the same effect that we had seen when Medicare Advantage moved into counties where they were focusing in high risk-adjusted costs, low efficiency markets, because that was the area where the most could be done by the ACO. So definitely perform that analysis for your ACO if you haven't already. And you can just select certain counties through your participant list. Speaking of which, this slide shows the physician level variation for an ACO in the Midwest that we're working with, and the horizontal axis shows not necessarily a bell curve, but really a highly skew curve where the contribution, what we call the savings and loss contribution, that physician's benchmark minus their savings. Really, there are some outliers that really pull the savings down. So the vertical axis shows these proportion of providers and the level of contribution to that shared savings range. And what we see is significant variation in performance among the participants. There are outlier participants to the left with upwards of 5 million in negative contribution to savings. Or if you're in a downside track, that really, one physician will expose you to 5 million in downside risk. And the majority of participants have neutral, more or less, performance, possibly some slightly negative contributions there with the negative $50,000. And really this skew shows how reinsurance and protecting catastrophic losses by physician is just such an important thing to do and to model, is to recognize the skew. And really, when transitioning to downside risk, only select the participants who are serious and have demonstrated that they are able to share to generate savings. And one approach that we're looking at with some ACOs is to bifurcate the ACO, where the physicians that are ready continue in the downside track, and then the ones who are not quite ready will go into a new track 1, and that essentially limits the amount of support that they get under MACRA, for AAPM bonuses, and but really it's the right thing to do for the ACO, because some of these providers are too risky to take downside risk on right away. And then the other thing to do is to really model the optimal track and parameter selection. So we touched on this a bit already. The optimal track really depends on many factors, including the types of participants and the programs, the care management programs that the ACO focuses on. So, for example, physician-led ACOs should really consider that track 1 plus. Despite it not having a higher savings rate, it qualifies for the 5% AAPM bonus, and it only has 8% of revenue downside risk. And that recognize that that's revenue for the assigned and non-assigned MSSP beneficiaries. But anyway, just keep that in mind. Also, make sure that you weigh the differences, the pros and negatives between prospective and retrospective assignment, and model the sensitivity of shared savings to the contract parameters. And this chart shows for a physician-only ACO out east what we had done when they were trying to figure out for their track 1 plus, what's the width of the risk corridor that they should select. This is an example of, they were performing so well that the probability, the estimated probability of them having savings was so high that by choosing a wide risk corridor, like a plus or minus 2%, they were really foregoing a lot of the shared savings potential that they had under track 1 plus for very little risk protection on the downside. So you'll want to model these corridor ranges and really get a sense for setting up the ACO under downside risk right off the gate, right out of the gate, set it up correctly with the right contract parameters for financial success. Here's an illustration of the importance of risk adjustment. So these are actual renormalization factors for the MSSP. So if you had an ACO in 2013 and did not do anything to improve coding and keep up with your population, what happens is that over time, the risk scores tend to erode. And this is because there's this inflationary factor to risk scores. And the other ACOs around you are or even in the nation, are improving risk coding. So since the renormalization factor renormalizes relative to the average ACO risk score, you'll want to keep this in mind, that every ACO is improving, so you need to continue with this effort. And one of the reasons why it should be done well before taking downside risk is because there's a 2 to 5 year lag before this starts to impact shared savings, just the nature of risk adjusters and when they impact shared savings. And also, it's such a difficult effort to coordinate because it is an interdisciplinary, clinical, financial, operational, scheduling, you name it. Everyone gets involved in this. So definitely pay attention before going to downside risk. Pay attention to your risk scores and make sure that you're competitive. Finally, so the ACO has through October to decide if they want to exit if something goes really wrong. And just remember some of the unintended consequences if you decide not to take downside risk and instead just unwind your ACO. There's a loss of program waivers. And really with these program waivers, the health system, for example, gets a lot of flexibility, and Stark and some of those fraud and abuse and all those waivers. So it's something that go away and would hinder a health system ACO. There's also loss of engagement with the physician community. So if you unwind your ACO and don't offer an easier route than MIPS under MACRA, you might lose some of that physician community, those referrals, some of the ability to manage the care of your patients. And there are other payers that are involved too than just Medicare fee-for-service. So if you have commercial risk contracts, MA or Medicaid, you'll also want to think about if dissolving the ACO just for MSSP, if that threatens some other more profitable risk contracts. And it also, you lose some of the data that you have to manage these patients under if you do dissolve your MSSP. So with that, I will leave it to Chuck to talk some about the ways that you can manage catastrophic risk.
Yeah, thanks, Andrew. And before I get started in these last couple slides, I wanted to remind folks that are on the webinar that to submit your questions to us. We will have a Q&A session here at the end after these next couple slides. Right now, I'm going to quickly cover some risk transfer options that are available for ACOs looking to take downside risk. Some recent examples that our clients have chosen include the purchase of managed care errors and omissions and directors and officers to protect the ACO from vicarious liability. Another example is using a cyber insurance policy combined with a robust information technology system to protect the ACO from data breaches. And finally, the utilization of an aggregate stop-loss policy, or for next-gen ACOs, a specific stop-loss policy to protect your downside risk. Aggregate stop-loss is a policy designed to limit abnormal claims frequency of an ACO's total paid claims expense at a predetermined amount. Most dual-sided ACO contracts will use the benchmark or total estimated claims expense plus a claims corridor to arrive at the predetermined amount, known as the attachment point. Once the attachment point is reached and exceeded, the ACO is reimbursed amounts greater than the attachment point up to the policy maximum. This coverage should be considered by all ACOs that have downside risk and can include all of the patient populations you're taking risk on, including Medicare, Medicaid, and commercial contracts. Here is an illustration of aggregate coverage. This is an MSSP Track 1 Plus ACO with a projected benchmark of $105 million or total estimated claims expense. They chose a loss sharing limit of 8% and a maximum loss sharing rate of 30%. They have determined that they can assume no more than $1 to $2 million of any downside loss, so they want to purchase an aggregate stop-loss policy with a 103% attachment point. The 103% attachment point equals $108,150,000. At the end of the contract period, the actual claims expense is $112,140,000, which yields a total loss of $7,140,000. Once you apply their 30% maximum loss sharing rate, they will owe CMS $2,142,000 in shared losses. Their aggregate stop-loss policy will reimburse them $1,197,000, leaving them with a $945,000 liability. I'm sure that one of the first things that you thought about is securing capital necessary to support your organization. There are many avenues to pursue, such as raising money from your physician or hospital partners, venture capitalists, an angel investor, or a line of credit at your bank. An out-of-the-box way to accomplish this is to use a medical malpractice group purchasing program. These programs can save up to 40% of the premium spend on medical malpractice insurance. They can help you accomplish two important goals. First is to help you raise money for your ACO by using the savings to fund the ACO. And secondarily, it helps to further your bond with your physicians so that they're more loyal to your ACO over time. If you're interested in any of these insurance solutions, please let us know. And now I'll turn it back over to John to put a capstone on our two webinars.
Okay, thanks, Chuck. So this is the final slide, and we wanted to leave you with 4 critical steps that I think would need to be taken as far as next steps are concerned. The first one we'd recommend is complete that risk assessment. I gave you one example of it. We really want you to have this risk assessment tool. So not only can you contact any of us, and we'll be glad to send it to you, I'm also going to pass it along to Garrett Schmidt, so it'll be available through ACO Exhibit Hall and be able for you to get it directly from him or through the Exhibit Hall. So complete that risk assessment. Remember, do it internally, get diverse components of the organization to complete it, then sit down and look at it totally, and then it's a good idea to get objective assessment of it as well. Secondly, model the downside risk tracks. That's what Andrew and Chuck have been talking about in their section here, and that's to take a look at it. Our recommendation, I think, collectively is if you're at a track 1, probably go to a track 1 plus and make that your next step for some of the reasons we've already presented, an example that Chuck just gave. Step 3 is after you've modeled it, select which risk model you're going to pursue after some internal discussion and decision making, and then proceed with getting the application completed. I think the letter of intent is due in July. I think the applications are going to be due sometime by the end of September in the scheduling from CMS standpoint. And simultaneously, I would encourage you to start implementing the risk management steps, those 5 steps that we just talked about earlier in this presentation. So I hope this has been helpful to you, and if you want to contact any one of us, let's go to the next slide, and you can find our contact information available there. And again, we'll make sure that the assessment tool is available to you if you want to start with that. All that said, thank you on behalf of myself, Chuck, and Andrew, and I'll turn it back to Garrett at this point.
All right, great. Well, thank you, Chuck and Andrew and John. At this time, we will have some questions from the audience here, and I will share these on the screen so that you can see them. Okay, and the first question is submitted by Daniel. It says, can an ACO take risk just in counties that they choose? Is that what you mean by regional arbitrage? If so, what is the key factor to consider when making this arbitrage decision?
Yep, I can answer this one, Garrett. So what's meant by regional arbitrage is that there are certain counties, as we saw in Illinois, where the regional benchmark is so high, on a risk-adjusted basis, because the other providers are inefficient with care, and so really, what's meant by regional arbitrage is to prioritize. When you're taking downside risk, prioritize those counties. If you're only choosing certain practices or certain hospitals, prioritize those counties in which you have essentially an edge, a regional edge, on the other providers on a risk-adjusted basis. And that's something we call efficiency. So if you're in your most efficient county, when you're the most efficient relative to the county's efficiency, that's where you'd want to focus downside risk, given that you have 5,000 members at least. And so you can't, the ACO is not like an MA plan, just to clarify. Where an MA plan, if they're a local MA plan, they can choose just certain counties to offer their coverage. It's not exactly like that, but you can certainly select a subset of your participants that have beneficiaries that are mostly in certain counties to essentially have that regional arbitrage pad your level of downside risk exposure.
Okay, great. And I know we're running short on time, but we've got a couple other questions. If you have to drop off, that's fine, but we will wrap up here in the next 5 minutes. Next question is, can aggregate stop-loss be bought just for certain populations, or do we have to buy the insurance across all of our members?
This is Chuck. I can answer that quickly. Yes, you can buy aggregate stop-loss for just a single population or for multiple populations.
Great. Quick and easy. All right, next question. Okay, if we can, this is submitted by John, if we can exit from downside risk in October after having signed up for risk from January, what data monitoring do we need to have in place to make sure we know how we are doing? And how real time can that data be?
This is Andrew again. Yeah, I can take this one. So it's very important to essentially do a monthly refresh when you receive new claims data, to do a monthly refresh of your forecast, including actuarial completion factors and seasonality and all types of very important actuarial adjustments to have an accurate forecast of how you're doing relative to the benchmark. And for October CCLF, if you can at least have about 2/3 of your claims experience to be complete. So any actuary worth their salt could probably get a pretty good estimate for how you're doing at that much through the year. And if you have to, I just point back to the unintended consequences of winding down the ACO. If you have to exercise this option to not be an ACO, a downside risk ACO in October, and that's only for MSSP, not for NextGen. If you have to exercise that option, then you should have a pretty good idea through August or through August claims. You should have about 8/12 or 2/3 of your experience completed. So with completion factors. So anyway, okay.
Okay, great. And we'll have time for just a couple more quick ones, and then we will close it out. Next question is submitted by Julia. How does continuous attribution affect risk scores for a new contract?
This is Andrew. Just a few, so a couple quick comments on this. I agree. The risk, continuous attribution, the risk scores are not allowed to increase, and those are the normalized risk scores. So that's unfortunate in MSSP. And what that really means is that renormalization or that decay in risk scores that we saw, you'll want to definitely keep on coding those beneficiaries just to keep up with the same levels of coding that you've had before. And Also, there is a regulation being scored by the OMB, the Office of Management and Budget, right now, and they are changing this changing risk adjustment. None of us have seen this bill, but that could very much change in the future. And finally, if you're thinking of a prospective risk track, there is actually some ability to code some of those newly assigned beneficiaries better. And you can reach out to me if you want to learn more about that. But essentially, anyone new to your ACO, you have a window where you can prospectively code them accurately and then get credit for that in the performance year. So.
Great. Okay, last question here, and then we'll close out. You provided examples, and this is submitted by Ron, by the way. You provided examples of MD participants. How mature are the processes and recommendations for post-acute providers? How mature are the processes or recommendations for post-acute providers?
This is John. I'm not sure if we're talking about the bell curve that we talked about with respect to MD participants, but as far as how that relates to processes and recommendations for those providers that are on the other side of an admission, for example, they're not as mature yet as I think we would hope they would be, but there has been significant effort, I think, coming about recently, largely driven by the idea of social determinants, that we're seeing more and more of a readiness, if you will, for post-acute providers to understand that they are an integral part of the overall care plan for patients and are beginning to be proactive in that regard, to be part of that management process.
Okay, great. All right. Well, that is going to conclude our webinar for today. For the questions that we were not able to get to, which actually we got to all of them, we could, for future reference, answer them by email. Excuse me. Also, if you have any specific questions for our presenters, I'm going to put up their contact information here again on the screen. And feel free to make a note of that and to contact them directly, and they'll be happy to follow up with you for further discussion. As we mentioned earlier, today we did record today's webinar, and it will be available so that you can review it or share it with anyone else that you would like, or see it again yourself. It will be available at the website at the bottom of the Q&A page here, acoexhibithall.com, in the reference library. You can do a keyword search to find it, or it will also be available at the Risk Strategies booth. And we would encourage you to go visit them anyway and find out more about them as well. So in conclusion, I would like to thank all of you for attending today. I hope you found it very informative and helpful. Hope you join us for the next one that we do, and have a great rest of the day. Take care.